How are you, Ron?
I'm good.
Good.
Thought I would listen in today.
Well, good.
See what you guys are talking about.
Well, good. We're glad you're joining us.
Oh, it's good to see you.
Good to see you too. Hey, Sherry.
Shelley, how are you?
I am well. How about yourself?
Hanging in there.
Good. Yeah, I understand. Matt and Dr. Moore, how are you all? I guess they're not on audio. I'm going to try to make a little less blinding light here in my. A little better. All right. I'm not sure how many folks are joining us today. Hi, Dr. Moore.
Hello.
Hey, Matt.
Hello. Good morning.
Good morning. Do you know, Matt, how many folks we may have joining us today?
We had 8 registered.
Okay. Is that including us or no?
That does not include you or me, Shelley.
Okay. I don't know last time how I showed 10:01, so I'm not sure if we want to wait a little bit or.
I think we can wait a couple of minutes. Excuse me.
Good morning, Dr. Ullman.
Morning, how are you?
I'm well. How are you?
Good.
Good. We're waiting just a little bit longer to see if we have a few more folks joining us. Well, while we're waiting, totally unrelated to our subject matter today or our book, I was just in a meeting with a committee focused on mental health parity, and there's going to be an interesting document that will be coming out that really helps all kinds of different stakeholders understand mental health parity. So I know our members will be receiving it because I think it's important for employers to understand what mental health parity is as well. But if anybody else is interested, when it gets completed, yeah, we'll get it to you, Ron. You're on our constant contact list, aren't you?
I think so.
I think I had asked for you to be added. We have lots of people on there, but
I should be. I've tried to stay on things.
okay, yeah, I'll definitely get that out. It's we were just working on it, trying to make it as simple as possible, and we really want legislators to understand it, but you know how that can be sometimes.
No, it's important. I was just talking to one of our folks in our area around this, and it's poorly understood and super important. So
yeah, and often there's not compliance with it. And I don't know, Ron, if you're aware of the lawsuit recently with United because they weren't in compliance. And anyway, it's called WIT. The lawsuit was WIT versus whatever, United Health Behavioral, UBC, I think it is. But anyway, it's interesting. They got in quite a bit of trouble. I'm not sure what.
Is that a Kansas state?
No, it was not Kansas.
Nationally?
Yeah.
Okay.
Yeah. I think it was a class action lawsuit. Someone whose daughter ended up, I think, overdosing because she wasn't able to get the treatment that she needed, of course. And so
we dealt with that when I was at Kaiser. It came up all the time, and it's super complicated.
Yeah. Yeah.
And important. So.
Yeah, absolutely. Well, we're at 10:04. What do you want to give it one more minute, or what do you think? I'm not sure last time.
I'm comfortable whenever.
Okay. Well, for those of you that attended last time, which I apologize, I was not able to be there. And so there was a recording, and I did listen to the majority of the recording. I got close to finishing it all. So I know those of you that attended, I think Dr. Allman and Sherry, it's more informal, kind of an open discussion. Again, the book is this one, and you have an opportunity to read it or not read it. And we just kind of wanted to walk through the book and help people understand some of the, excuse me, the points that were in the book. And we are in part 2. We're going to have 4 of these. This is our second one, and we're on part 2 of the book, which I think was, I don't know, 3 chapters maybe. It's a really easy read if you haven't read it. But anyway, we did send out the, I don't know if, I think it was Friday actually, some questions to prompt conversation today. But I just wanted to open it up kind of before maybe we get to some of the questions. And I'm Dr. Moore and Matt, you guys jump in, but I don't know if anybody had anything you want to talk about. Because this really is your time. We just wanted to put some questions out to prompt conversation and discussion. But before that, anyone, or maybe it would be good for us to do introductions, since I know Ron is here and you were not here last time. I'm sorry about that. So why don't we go ahead and do that? I'll start. I'm Shelley Duncan, Executive Director of the Business Group on Health. And let's, Dr. Moore and Matt, you go next, and then we'll go from there if you would.
Sure. Justin Moore, I'm the medical director at KBGH.
Good morning, I'm Matt Tebow, project director with KBGH.
Okay. Ron, why don't you go ahead?
Hi guys, I'm Ron Whiting. I'm the executive director of the KC Health Collaborative, and used to live in Wichita. In fact, Justin, I don't know if you remember me, Justin, but I remember working with you when you were a med student many years ago. So it's nice to see everybody.
And if I can just say, Ron was the original executive director of this organization, and it was called the Wichita Business Coalition on Healthcare back then. So Ron was really the brain behind the whole organization. So did a lot of great work and started the organization in a really great way. So
glad to see it still going. So
yeah,
thanks for letting me drop in. Yeah,
it's been a while, but it's just interesting to see how some of the things that were discussed back then are finally possibly coming to fruition. So we're excited about that. Anyway, thanks for being here, Ron. Sherry?
Hi, I'm Sherry Pate. I'm a Human Resources Director at Intrust Bank.
Super. And last but not least, Dr. Allman?
I'm Brandon Allman. I'm a family med physician and small business owner, and have a direct primary care practice, Antioch Med.
Super. Okay. So back to what I was saying earlier. Anything anybody has to say, or anything anyone has to say before we kind of kick this off?
I'm by no means an expert, but I've been in this world for a few years now, and usually these books just kind of remind me of things. There's relatively little kind of surprises in these books. I'm just reminded of things. But the one thing that really surprised me here was the Dave Chase's claim that a lot of organizations only allow claims administrators only allow audits on something like 0.01% of all claims, which seems really low. I can see them wanting to limit it somehow, just so they don't get buried in paperwork. But 0.01% seems low, and I was curious what other people's thoughts were on that. But
I agree. It seems very low.
Yeah, I've never heard a number mentioned with regard to that, so I don't even know. I don't know.
Yeah.
And it certainly can't be, that may be what they do, but it's certainly not what they can do, right?
Right. Yeah.
Which makes your second, the point about being vigilant important. So.
It makes me want to read my contract again very thoroughly.
Yeah. No, I'm sure. Me too.
So Sherry, I'm assuming by virtue of what you just said that you really don't have a sense of what that is. I mean, not what it is, but the percentage.
I don't remember a percentage being referenced, but admittedly, I haven't looked at our contract in months. I know that there's language in there that permits audits, but I couldn't tell you the detail.
Mhm. Is the contract, how long is like your contract? How many pages? Is it just pages and pages or?
It's probably about 75.
Oh, yeah, yeah.
Mhm.
That's a lot to read and process and yeah.
I'm thankful for our attorneys, very thankful.
Oh, right.
And to me, it was just kind of like another indication of just larger problem of this smoke and mirrors opaqueness in the system that is intentionally created that way so that money can be made without employers, purchasers realizing where their costs are actually going, and the lack of control that's really systematically put in place by these types of rules and stipulations that are put in place. And then even how they talked about how this problem of the low audibility, or however you would put that, the low frequency of audits is really caused by the negotiation between the providers and the insurers, because that's kind of a, I think as he puts it in the book, a wink, wink, nod, nod thing of kind of a, we won't audit you as long as you let us decide our own prices on what we charge for services in the hospital or whatever the case is. And so just kind of this perpetual problem of opaqueness in the system that allows middlemen and others to make money where there's really no value being provided.
Mhm.
Yeah, it's an interesting point. Obviously I was a little kid when this was going on, but my understanding is that back in the 70s, the airline industry really, all their prices were set by outside regulators, and the airlines competed on price, or didn't compete on price, but competed on service. And that's sort of the way the German system works now, where everybody decides, no matter which doctor you go to, no matter which insurance plan you have, procedure A costs X dollars, right? And so people have to compete on other things. And it seems kind of anti-competitive in a way, but I wonder if a kind of 70s airline model is almost worth it just for the sake of transparency. Or maybe you don't have to give up that much to get transparency. Maybe we just need to be harder nosed, sharper elbowed.
Mhm. Interesting.
Maryland does something similar, right?
Right.
And then people like to talk about Taiwan, I think, as a healthcare system. And if you unpack that a little bit, you also find at the heart of it price controls.
Mm.
So it's pretty compelling. I would agree.
Yeah, it's everybody gives Grand Junction, Colorado, the credit for having this one payer model. But you're right, Maryland's been doing it since like 1980 or something. They've been doing it forever. It's amazing.
Yeah, Grand Junction, I'm not up to date on the very latest, but it's a market I followed. And the interesting thing about Grand Junction is that it really boiled down to a very competitive yet friendly relationship between a set of physicians and the health plan.
That's interesting.
And that's another feature that's it's an interesting feature when you can develop a much more a different kind of relationship between the provider and the health plan, and that's a market that illustrates that as well.
Mhm.
Yeah, I wish we could get Bob Badgett into one of these meetings. He works at KU, and he claims that the thing that I'm bending his words a little bit. He ought to speak for himself, but he says something to the line of, if you have mountains or coastline, you can get rid of predatory behavior. But if you don't have mountains or coast, it's very hard to stamp that stuff out, because people get so self-conscious about attracting providers that they let stuff slide.
I hadn't heard that, but it's a great way to unpack what's really going on in the competitive dynamics, right? Of what does. Yeah, it's funny.
Well, one question I have related, sort of, well, it is related, but in the book, it references a situation where one woman had, I don't know what it was, 4 hysterectomies, and somebody else, I can't remember, a circumcision or something. My question is, I wonder if those people, those patients get any kind of EOBs or, I mean, does the patient, I mean, would they ever notice anything like that? It just seems there's a lot of gaps in the system then. And I don't know how often that kind of thing happens, but I mean, obviously they pointed that out, but.
Every day.
Is that right? Yeah, I was interested. I mean, it was amazing that he said that 10% of claims were fraudulent, which that seems super high. I knew it was a big number, but 1 out of 10 seems high.
So I don't, fraud, you know, I would just say fraudulent's a strong word. Wrong would be another way to
Erroneous.
say it. And having a fair amount of experience in this, well, it's not fair, but I just know from personal experience, put it that way, that even when you're the recipient and you ask, I know of several cases where if you go back and actually have them explain to you what's in the EOB, the story starts to change. And it just happens. And I think it's more almost an artifact of a really arcane system than it is, you know, in malicious intent. Although I would say the malicious intent is around keeping the system that's so arcane that creates these problems. But yeah, it's, you know, anybody that ever gets a bill for which you bear any financial responsibility has to have them clarify exactly what they're paying for. You just have to.
Yeah, I'd appreciate Dr. Allman's input on this. One of the weaknesses of the CPT coding system is that it's kind of blunt. To where sometimes you end up submitting a CPT code that it doesn't really describe what you did. It just gets closer to describing what you did than anything else. And that's how I wonder if that's how somebody ends up with 2 bills for a circumcision. You know, the second one was just some revision of the original surgery that there was no other code for it.
I think that's definitely true. We have patients that we review bills from entities to try and help explain them in our office, and it's very opaque. I think again, going back to like why is this lack of transparency? I think there's desire on both sides to be transparent, both from providers. Like I was on a call with a hospital system that's trying to give a transparent price for deliveries, which has been a 4-year conversation that may come to fruition in the next couple months. But even though they want to do it, like the description of how it even goes through the system and how they know if this contract is like, how do we even know if there's a complication that's outside of this contract? It was just a major barrier. And so I think the desire is there. I think the systems, people are just so enmeshed in the current system that there's this energy barrier to step over it that is only a few people are willing to do now. So, but I think it's growing. So that's the good news.
You know, that would be, I'm not exactly sure what it would look like, but you know, as a coalition activity, you know, burrowing into just the process, it could be very illuminating. For example, I worked in a health system many years ago in Southern California and had a new CEO who was a physician. And long story short, we ended up putting in the largest conference room we had, everybody involved in the processing of a claim and a bill in the health system, and put them around the table and had them describe their role from person to person. And it was probably one of the more illuminating activities I've ever been a part of in healthcare, and also sort of depressing. But I think you could, I mean, it's really phenomenal. And I would think you could actually do that with your, you know, with your employers and your health plan and your broker, is set up a roundtable that actually talks about that transfer of information that goes on as a, you know, visit to the provider, gets turned into a claim, gets turned into a bill. It could be interesting.
That's a great idea. Yeah.
I can't remember if it was in this book, but they gave the example of basically paying employees to find mistakes, that they paid them a percentage of that. Was that in this book that was talked about? But there's an employer that just said, hey, if you find a mistake, you get a finder's fee.
Oh,
so.
Yeah. Mm-hmm.
That's great.
And you know, this isn't anything really related to the book, but it speaking of patients, you know, we have a personal situation in our family where my daughter was in the hospital, and anyway, she was charged with receiving oxygen, and she never received oxygen. And she's still trying to fight it, because it's basically the hospital saying, yes, we provided you oxygen, and her saying, I know you did not give me oxygen. And, you know, meanwhile, she's got this $1,200 bill or whatever it is looming over her. And, you know, where do you go in that kind of a situation? Because it really it's their word against hers. And, you know, unless you can go in, and I mean, I suppose she could get an attorney or something and try to look at the actual you know, records in the hospital or orders or something like that. But it's tough when you're on the patient side of it. And she tried to engage her employer, but you know, what are they going to do? It's kind of the same situation with that. So it's beyond transparency, I mean, in some ways, but when you consider, you know, patients at the end of all of this and kind of not understanding things and then not knowing what to do about them, that just it's a whole thing. So well, speaking of hospitals, and were you going to say something, Sherry? I'm sorry.
Yeah, no, it's, you know, just thinking about the errors and the frauds that lead to claims being wrong. You know, several years ago when we were with a different TPA, it was within the first week of transitioning to this group, well-known national carrier. The phone calls began literally on January 3rd that claims weren't being processed correctly. And, you know, so I, you know, thinking about the experience that our employees went through, it was a rough, probably 6 or 7 months of us being stuck in the middle as the employer, trying to be an advocate for employees, trying to make sure things were set up correctly on the health plan, based on our documents and how we wanted things processed. And, you know, honestly, after fighting with the carrier for months, we finally had to sit down with our company president to say, this isn't right. They ended up having to completely reestablish our structure and reprocess 9 months worth of claims that had not been processed correctly. So there are just so many moving parts and pieces when you think about this whole, all of these dollars that are involved. When people were getting refunds, they were getting new bills. We had thousands and thousands of dollars coming in and back out of the health plan itself, just trying to balance and right size it. It can be a big deal.
Would you say that your company president had to become involved?
Mm-hmm.
Mm-hmm.
Yeah. It was at that point that we knew we were marketing the plan to move away from that group because we just couldn't stay with them.
Oh, sure. Yeah, absolutely.
Sherry, can I ask, is that claims that were being rejected that should have been approved, or vice versa, or the correct amounts not being paid, or what were like the main problems that were arising from that?
Yes, it was all of the above. They didn't have the network assigned appropriately. So providers that, if you look them up on the website, were identified as in network, they were processing as out of network. They didn't apply co-pays and deductibles correctly. Things that should have been excluded were paid. Things that should have been included were denied. I mean, it was just a disaster. Nothing of which I've ever seen in 25 years of working in benefits.
Wow. That's interesting.
It was a mess, you know.
We've at our office, we've only been tried to be paid by a TPA once, and our billing is literally a name and $50 next to the name. And so it's like all they had to do is write a check number times $50, and we never got the right amount from them. Not one month. For the whole year we were paid by a TPA. I even gave $700 back as just a credit to the company and said, hey, we were given this money, but we didn't ever bill for this. So we stopped being paid by a TPA after that.
Well, if I may ask, was it a carrier TPA or an independent?
This is an independent one. This is, and
Really?
I think a very forward-thinking one, even one that was excited to like work with TPC, but they had this complicated code list that they would send us, and I'm like, literally, I'm emailing you every month with 50 times a number. You just have to write a check for that amount. Like, that's it. And
wow.
and it again, I think it could be fixed over time, but it was just very surprising because I called them multiple times and trying to give money back to them, and they're yeah, just hold on to it. So it was funny.
Well, and you think about the amount of time, I mean, that you spend, and Sherry, you all had to spend that whole administrative, the amount of time you spend in trying to correct that, and time translates to dollars. So yeah, interesting.
Yeah,
Well-
the administrative overhead is the third biggest source of excess spending. Yeah.
Oh yeah, yeah, absolutely. What, Matt? I'm sorry.
Oh, I was just going to say, Dr. Allman's one of the honest ones that tried to give it back. You know, there may be others who would try to take advantage of that system. You know, so
Sure.
you know, exploit the complex nature of the TPA and try to extract more of those dollars that you
Mhm.
didn't really earn. So you know, kudos to Dr. Allman and Antioch, but you know, that also kind of speaks to his larger problem of all these problems exist, and even the ones that try to do right still can't, you know, do right in the system.
Right.
And it's interesting to me to hear, Sherry, your experience with that carrier, that TPA. It's almost kind of like a combo of what Dave talks about in the book about the auto adjudication and how that can cause problems if you just pay everything without really paying any mind to it, and you pay, you know, whatever it was in the example in the book, 758 units of laboratory or whatever it is, just some, you know, very random number that doesn't explain what the service was for. You have that, but then you also have what you experienced, where things that are supposed to be paid aren't getting paid. And then again, just adds to the administrative complexity that we were talking about, how that then adds costs, and how just these inefficient systems are costing payers, providers, patients so much more money just because they're just too complex.
Yeah,
Well,
you know,
it
I would
leads-
be, go ahead,
Oh,
Sherry.
I was gonna say, it leads to such a feeling of distrust too, because this is, I mean, the situations that we were in, I mean, oftentimes what was most concerning, you know, set the dollars aside. This is people's health and the health of their families. And when you can't get treatment for, you know, whatever your condition is, or you can't get a medication that you need. And I know part of what this section talked about in particular is how we're so overtreated, but you know, I think for people when they're in that situation, they just want to feel better. And so we were, you know, stuck in this limbo of people not being able to get the care they need because things were so broken on the TPA side. And that was the frustrating part.
Was your, Sherry, was your broker involved in trying to help right that wrong?
Yeah, at one point we had weekly calls set up just to walk through the list of issues. I mean, you know, you were talking about the time and resource drain. I felt like that's all our benefit team did for months, was try and get to the root issue of the plan just wasn't set up correctly. And you know, the frustration of our employees and their families was you just opened up the notebook and said, well, who's calling in today? Because you knew it was going to happen.
Oh my. Gee. Yeah, that's wow. Well, speaking of brokers, this is one of the most interesting things for me, kind of out of this book. And again, you know, not having obviously any kind of extensive HR background, I found that really interesting. And one of the questions that we had was regarding, you know, broker consultants. And I'm just curious, Sherry or anybody responding, what kind of, if you feel like that there's transparency, speaking of transparency with your broker consultant. And, you know, if you, and one of the things it talks about in there is it's one thing to know kind of within your own contract, but from an aggregate standpoint, you know, how much compensation, you know, they're actually getting. And the other thing that I would note, having some friends in the industry, is other benefits that they receive, such as trips and that kind of thing. I mean, I know a friend of mine that's a broker consultant used to work for a different company, and when she wasn't a broker consultant, but the carrier would send like 10 broker consultants to, I think one time they went to somewhere, I want to say Pebble Beach, maybe, but it's just like this, you know, 7-day big trip with their significant others and a week of golfing and that kind of thing, which you probably would never know in terms of what compensation. But anyway, what's your take on that? Do you feel like you have a good sense of your broker consultant compensation.
Well, I did until I read this book. We actually, for years with Lockton and even with IMA, when we partnered with them, we would get annual disclosures of the percentages that they would get from the health and welfare side of the business. I really suppose it was naive to think there weren't other forms of compensation baked in. And, you know, after reading that particular chapter, you know, you take a step back, and hindsight is always so crystal clear. You almost wonder if that leads to, or you don't wonder, you're like, oh, that affirms the thought that we were steered in very particular directions in terms of relationships and partners. And some of those relationships were good and some really were not. And so you wonder, clearly you don't have my best interest as a client at stake, because you kind of knew this was going to be a cluster from day one based on what you learn. Again, hindsight being the clear photo that you have. So yeah, it's kind of a frustrating feeling, but no, I don't think we have any clue.
And another question I have, and I found this to be true when I was the CEO of a larger nonprofit organization, the comment about it's kind of at the very last minute, you get your quotes. And I found that to be true. We went through a number of different broker consultants, and it seemed that it was always at the very last minute. And because, you know, you have your plan year starting and you have to make a decision very quickly. Have you found that to be true at all? And I would open that to anyone.
Yeah, you know, we're a calendar year health plan year, and because of our planning processes, which can take some time, we've actually forced the issue to begin renewal discussions in June and July, but it's been an uphill battle.
Mm-hmm, mm-hmm.
I feel like when I read about the broker, I always come back to the saying about Google, or so if it's free, you're the product. So if you're not paying for it, you're the product that's being sold. So that's true if you use Gmail, and it's true if you really in anything. So if you're not paying your financial advisor, you might be the product too. So that's what I thought of in coming back to this.
Yeah, we're seeing this kind of minor rise in cash-based brokers. Ron, are there any in your neck of the woods, guys that just work on a pure cash basis?
Yeah, I don't know. I haven't heard of that, but I don't know. It could be happening. In Kansas City, I'm not as close to the broker employer community. So, but I know having said that, I'd be surprised there's a lot of brokers in Kansas City. So yeah, I think that would preclude that kind of.
The irony is that Sherry could speak to this, but I mean, a good honest broker is worth a lot of money. I mean, so I think a lot of people would be willing to pay them a lot of money on just a cash basis to get good advice and sort of eliminate all this sort of shady stuff in the background.
Yeah, I mean, the thought of having to navigate those waters with just my benefits person, and I mean, that's a scary thought. There's just so many things that we don't fully understand, and you don't get into the depth of it. So having that partnership really is valuable when you're confident that you can trust it.
Yeah. Have you, I had never heard of this actually until I read the book, the Health Rosetta. And that, I mean, I think is it a certification that broker consultants can get in that? I don't know of anyone in Wichita that has that. And I don't know, Sherry, if you or
they don't. Health Rosetta has a map. And so in Kansas, the last time I checked, there was one in Kansas City that was Health Rosetta certified,
really?
But I haven't seen anybody else in Kansas. So the Health Rosetta makes them sign a disclosure of how they're going to receive compensation, and then they have disclosure requirements to their customers as well. And most of the brokers are paid on savings, like that's how they structure their contracts initially. So
well, that they have some of those forms that I think we get into in some of the later sections about, you know, right now we're really admiring the problem and how messed up the system is and where all the faults lie. And then the last two sections are what resources are out there. And Dave has some pre-developed forms that you can just give, any employer can give to their broker to say, we want to know where all your forms of compensation are coming from, not just from ours, but like Shelley said, from the aggregate, where are you getting paid?
I think there was just new legislation on this topic too.
Yeah, it'll be interesting to see how well the two line up. Does the legislation line up with the Health Rosetta stuff? Because I don't know either. And I suspect smart brokers will find other ways to to get paid, kind of without disclosing it. But we'll see.
It does
Well,
seem.
Go ahead, Ron.
Going after the advisor / middle person doesn't seem like a, I don't know. I'm sorry, offhand, it doesn't feel like a good strategy, but I get it. But it, you know, that doesn't feel like an end game. It just feels like a way to, you know, manage another part of the messed up process.
Yeah. It's one component of that. And I think, you know, for me, and one of the things we're talking about the business group is just transparency.
Yeah.
I mean, let's just be transparent about things. And I had heard relative to that legislation, and I can't remember if this was in the National Alliance Health Policy Affinity Group or what it was, but and I think it was an attorney saying that there'll be lots of loopholes. Like the intention is good, but practically speaking, you may not ever actually get to. But if nothing else, I think it's good for people to understand, employers to understand, you need to at least be asking the question and let your broker consultant make them aware that you are understand that you're knowledgeable about how that whole payment structure works, if nothing else. But yeah, it's not going to solve the ultimate problem because it's so multifaceted. Ron, I agree with you on that.
I think, and pointing fingers at physicians too, like, I mean, physicians are conflicted as well. So Dr. Moore brought up the last time, like, if you own your own imaging, it gets used, right? So physicians there's conflicts all along the chain. So physician, advisor, and then insurance company with the medical loss ratio that he talks about. So the incentive is pointing everybody for higher costs. So that's where, yeah, changing the incentives is the ultimate solution along the chain.
Mm-hmm.
Well, something else that makes me think of too is actually a quote from you, Dr. Allman, from a couple of years ago, where you said you work for whoever you get paid for. Something along those lines. I'm kind of,
yeah, you work for whoever pays you.
Yeah. So whether you're working for the insurance company or, you know, and it goes for anybody, you know, we're kind of laying it on thick on brokers right now, but this goes the same for PBMs. You know, what drugs do they put on your formulary? They're going to put whatever drugs on your formulary has the biggest rebates that they get to keep the majority of, that pay the highest price. And so this theme runs through to pretty much anybody in the healthcare ecosystem of track back to where they get their most compensation from. And that's the relationship that they're going to be most concerned on nurturing.
Yeah, even when I talk to other healthcare professionals that want transparent pricing, Blue Cross Blue Shield is still out there as like, but if I do anything that crosses them, I'm not doing this. So that's the slowdown, unfortunately.
Well, that kind of lets you know who's in the driver's seat. Oh gosh. Well, yeah, speaking of PBMs, I'm just curious. Well, Cher, I'll pose a question to you about, I mean, how involved are you? I mean, obviously you make the decision who the PBM is, but do you have any other involvement or understanding of the formulary? Or I know that we're employed. The formulary changed with the new plan, and no one really knew about that until somebody went to the pharmacy to get some meds. So I'm just curious, kind of talking about that a minute.
Yeah, I won't claim to be an expert, but we were pretty involved, particularly when we moved to our current TPA or PBM rather. We had our broker run a disruption analysis, so we knew exactly what changes we might see in the plan. It was very minimal, which was good. And we worked with the PBM and our broker to basically provide as much information to employees as we could ahead of time, and worked with the PBM to personally contract the people who were going to experience a change in medication, which ended up being less than a dozen when we made the change.
Mm-hmm.
And, you know, again, if I think about culturally who the bank is, we don't like to rock the boat for employees, which I don't think is a good thing all the time. But I think in terms of communication, it at least helped put us in front of what could have been a situation where you don't want somebody to go to the pharmacy and find out, oh, that your med's not covered. So I don't know that I don't know that we have enough knowledge. We're not healthcare professionals to really influence the formulary, but we do have the ability to understand what it means to our population.
Yeah, PBMs are one of the more frustrating parts of this whole thing to me. You know, I just pulled up the list of the most profitable pharmaceutical companies in the world. Right now, Johnson & Johnson is number one, and they still make about 20% less annual revenue than any of the big three PBMs. The big three PBMs all make more money than the most profitable drug company in the world. And honestly, as far as I could tell, most of what they do could just be automated. PBMs had a really good role back in the early 80s when we had this big influx of new medications and we were trying to manage supply chains. But I mean, it just seems like most of that could be handled by a high school kid with a laptop computer at this point.
Yeah. And, you know, if you ask the average person what a PBM is, I would bet they have no idea. And I think it's exactly what you said. The PBMs are making far more profit than the pharmaceutical companies. And yet I think that's where everyone, when they think of high costs, it's the pharmaceutical companies, and they're really the bad guy in all of this.
I think the other piece to consider with this too, oh, sorry, go ahead, Sherry.
Oh, no, go ahead, Matt.
I was going to say the other interesting piece, I think, to this is we look at how much profit they make. But profit in and of itself, to me, isn't a bad thing. If you're providing value or a good service, it's okay for you to make money. That's how businesses work. But the thing with PBMs is they provide so little value for how much money they extract out. To me, that's where the real issue lies.
Well, and you know, what's scary to me sitting in the seat that I'm in, you know, benefits manager for a mid-sized company. We cover 1,400 people on our health plan. There's so much red tape and mystery around how all of these different pieces fit together to make up the healthcare that we deliver to people. You know, number one, just getting access to our data was a real challenge for several years. And then when you finally get your data, you're almost overwhelmed to the point that you don't know what to do with it. But when I think about how that translates to the PBM world, you know, currently we use UMR for our TPA, and we carved out the PBM completely separately. And that came about as an opportunity to reduce costs, to implement a formulary, and those things seem good. But at contract renegotiation, if you could have captured the look on my face when our projected rebates for 1 year are anticipated to go from about $130,000 to $450,000, pure shock. And, you know, from the employer's seat, do I want to save more money through the plan? Yes, I want to save more money through the plan, but I wonder where was my other $300,000 for the last 2 or 3 years? And, you know, I think the challenge is just, again, trying to navigate how do you know what the right thing is? And sometimes you just feel kind of lost.
Well, the whole rebate thing just, it is perplexing to me. I just, why? I mean, why don't we do away with rebates?
It's a toxic circular relationship. The drug companies want their drugs to be moved up the formulary. And so they basically, they pay for their drug to be moved up the formulary by agreeing to rebates. I mean, it's like Dr. Allman said, it's a matter of misplaced incentives.
Which I understand that, but then it's like you know, it's like smoke and mirrors. I mean, because really they end up, at least the PBMs.
So Dr. Morse,
a lot of it.
Go ahead, Brandon, sorry.
Well, I was just going to say to your comment earlier about a high school student with a spreadsheet. So I actually had a medium-sized company send me their drug spend for a year. And if I had just filled a generic for generic drugs, they would have saved 20%.
Yeah.
And that's like no specialty drugs whatsoever. Just me filling a generic at our office that they filled at pharmacy was a 20% savings on their overall drug spend. And it was just like, what is the point of a PBM at all? So I couldn't answer that question.
Yeah.
So if I developed some new life-saving drug and tried to market it for $2 a dose, no PBM would include it on their formulary. But if I made that same drug $200 a dose and promised the PBM a 20% rebate, it'd be at the top of their list right away. I mean, there's no incentive for them to encourage lower drug prices.
Mm-hmm. Yeah. Kind of like the claims problem too. When I remember reading that same thing, the more claims the insurance, the carriers are paying for, the better for them.
I think oh, sorry, go ahead.
No, you go ahead.
I was just going to say it seems like there are niches of transparency in each of these markets. So from the physician side, the broker side, the TPA side, the PBM side, it's just, Shelley, in your position, like how do you find all of those transparent ones and then put it together in an actual thing? So that seems to be the hard part.
I think I would just build on that, Brandon. I think that's exactly right, is the challenge. And I was going to suggest, this would be an area where the providers, the physicians, would be interesting, just like Brandon said about his experience with drug use, is if you opened up on a broader scale the input from the provider community about drug spend and generics and when they're appropriate and when they're not. And what I'm getting at is, at least in my experience, the more the providers are in charge of the formulary, just to kind of make it simple, the better. Mm-hmm. Right? Because at least two things, one, appropriate use of generics, and I'd rather have the provider making that decision about generic use. And two is the degree to which, there are individual differences in how people react to drugs, and the physician needs the flexibility in their clinical judgment to be able, on certain drugs especially, to flex. And so those two dynamics, so again, it would be another area of interest that you could engage the providers potentially in the community around, is developing a little better insight into drug use and some of the dynamics around formulary. And it would be a fairly innocuous way to draw some transparency on that process with the provider perspective. It's just another idea.
Mm-hmm.
So at one point in my life, a very brief point, I was a lobbyist, and I went to Pat Roberts' office to lobby in favor of pricing transparency for specialty drugs. And they were very proud of the fact that they had beat down a rule that would have further limited how much money oncologists could make off of giving chemotherapy. The average oncologist in America makes about 2/3 of their money off selling drugs to their patients.
Right.
And so when Medicare was trying to cut down from whatever it was, 7% to 4.5% or something, they were just furious. And Pat Roberts' staff was so proud of the fact that they had defeated this rule. And it's just so weird.
So when I was in Wichita, one of the first things that I wanted to do with the Business Coalition was get data around cost related to utilization. And I wish I had a copy of it, but I was the subject of a joint letter between all of the health plan CEOs to the department. I can't remember at that time, but it was like within the health policy authority that had control over the data, specifically denying me access, right, to all that. And they are proud and it tells you who they think of as their customer, unfortunately. So. But this is why again, the employers have got to, this is the transparency issue, is that the employers have the only lever that works in all of this, in my opinion, is the employers. Because that's the only voice that we'll listen to. And I was just thinking while we were talking, I used to, my mantra in talking with employers used to be, what are you paying for? Meaning, when you buy healthcare for your employees, what are you buying? Like literally, like what are you buying? are you buying health? Are you buying attractive, employment? What are you buying? Because I thought that was the most important thing for them to begin to understand the role of health insurance as an employer. But listening to this conversation, I would add, literally, what are you buying?
Yeah.
And so it's a question that continues to need to be answered, and even just the seeking of that information can begin to activate action. So it's,
No, that's a great, I really
Yeah.
love that framing, Ron. I think if we were buying health in America, all the primary care offices would look like Dr. Allman's, and all the hospitals would look like the VA, right? But there's just so much more signaling involved in the system than there is pure outcomes. We don't measure productivity and actual health. We measure
Dr. Moore, you talking about a meeting with Senator Roberts. There is going to be a meeting, a webinar tomorrow morning, and the National Health Leadership Council, somehow I got an email. I don't know if I sent it on to you or not. If I didn't, I apologize, but it's going to be with our new Senator Marshall. And they listed all of their priorities, of which they're very progressive. And I'm really curious to see what his stand is on some of these, many of the things we've already talked about.
Yeah.
So,
it's always interesting having a doctor as a
yeah. I'm just curious to hear. I mean, I know his stand on a number of policy issues, but I'm not really sure on the healthcare side of things where he stands. So it'll be interesting.
Yeah.
Yeah. Well,
Curious about.
Go ahead, Matt.
One thing I'm curious about as it relates to PBMs and formulary placement, from just an outsider looking in, Sherry, what's the process like when they bring the list of drugs to incorporate on the formulary? Do they give you a list of options and say, here's, clinical efficacy, cost, here's alternatives to it? Or do they just say, here are the ones that we think we've best identified as the best drug to put on the formulary? Or how does that process work?
It's probably, I would say somewhere in the middle of that. And again, at the employer seat, we're not clinical experts by any stretch of the imagination. And so we, again, had to rely pretty heavily on our broker, and the group that we work with has a pharmacy specialty team. And so we were actually able to sit down with their pharmacists and have them kind of help translate for us, again, both in terms of disruption and, one drug versus another, what you gain, what you lose, or are they equal? And we really took our cues pretty heavily from them, in all honesty. We just don't have the knowledge.
Sure. And that makes sense. And part of the reason I ask is I wonder if the, whether it's the broker consultant and or the PBM kind of knows where the employer wants to go in terms of rebates obtained. And so they more chase after the drugs that have the higher rebates rather than the drugs that have the lower net cost. And so that's helpful to know what you say there in terms of kind of what the process is, because I can see how that would be so difficult. And something else I wonder too, I don't know if anybody knows the answer to this question, but I know it's not a thing anymore, but the old pharmacist gag clause where they couldn't recommend a cheaper alternative at the pharmacy if one existed, does that exist on the system level, something like that? Anybody know?
I don't think that's a federal rule. I think that's a state by state rule, but somebody may correct me if I'm wrong. And I don't know where it stands in Kansas right now, honestly.
And I thought that there was some reference to that in some of this legislation that would in that, or at least attempt to do that. But it may have been gag clause related to something else. I don't know, but I'm pretty sure I saw something about that. And again, probably a lot of people don't understand that.
I'm gonna have to drop off in a minute, but I think just from my perspective, this discussion about the drugs is obviously a big part of expense, but I also think it's a little bit of a distraction. Because and it's so not to minimize it by any means, and especially in terms of the transparency and the things we've talked about, but it, you know, relative to, for instance, to the rest of the questions that you put out in terms of, you know, overuse, misuse, underuse, I'm, you know, I think that's got to be also part of the conversation, because if you allow a conversation about drugs, then you get into a whole other arena that doesn't get to the roots of really, you know, the challenges we have around utilization, appropriate use, and not to mention all the things we started talking about in terms of the way that it's billed. So I just would throw that out, that it's you know, legislators love to talk about it. It's kind of a popular thing to punt around. Just not sure where it gets us in the end. I mean, as an employer, you know, you might have a different opinion because the dollar amount can be so hefty, but you know, for the bigger picture of healthcare, I'm not sure.
Well, I understand and agree, Ron, and it makes me think about some of the things that we put for our questions and haven't yet talked about, but they all kind of come together. Like, you know, leapfrog is something that we, you know, was mentioned in the book. We're a regional leader for leapfrog, and they try to look at hospital transparency. One of the things that they're adding this year in terms of their survey is misdiagnosis, which one of the other questions we had was about cancer. And I was really surprised about what was it, 26% of cancers are misdiagnosed. Well, then that leads to medication. And what we were talking about earlier, and I think Dr. Moore, you were saying oncologists make their money. I mean, all of those things are just so related, and, you know, kind of like peeling the layers off of the onion with that. But it's, yeah. And, you know, how do you address it holistically? It's kind of like you do have to address one thing, you know, after another. And then when you look at policy and legislation, and you're dealing primarily with people that are not healthcare professionals. I mean, we do have some, but it's overwhelming. It can be certainly overwhelming.
Absolutely is. It, you know, the other area besides cancer that has been popular, and this is, again, you know, if you look at some of the activity nationally, and even some of the national brokers have done some interesting work. The other arena that comes up is orthopedics, and particularly total joints and back. And it's another, I would put that almost at the top of the list in terms of you know, misdiagnosis, overdiagnosis, and overtreatment. In fact, I've been involved in some of the national efforts around centers of excellence, and one of the things that they throw out is something like 40% of joint diagnosis for replacement can actually be dealt with non-surgically, or are, you know, inappropriate. And so when we pay for the national centers of excellence, one of the things they want to pay for is reconfirmation of diagnosis. Mm-hmm. So anyway, just another area of interest and potential transparency. Oh, so yeah. I appreciate you guys letting me drop in. I love to keep track of what's going on in Wichita, and that you keep having at it. I can't wait to come see you in person.
Well, yeah, thanks for joining us. We appreciate your feedback, and come back to our next one.
Okay. Good to see everybody.
Good to see you, Ron. Take care. Well, we're wrapping up here. We've got just a couple minutes left, and so I'm trying to think if there was anything. I think except maybe from wellness. We had one on.
I had one comment on that. If that's,
what's that?
I said I had one comment on that. It was, reading that as a primary care physician was just funny to me, because what they're describing is just like quality primary care. like the USPSTF guidelines, like that's a line item in all my new patients' notes, like all USPSTF grade A and B recommendations covered with this patient. And so that was hilarious to me, that it was the business's job to do that for people. It's like,
and it's just it's a list, right? So you can just go down the HEDIS list. It's pretty nice. Yeah.
Okay, well, we have 1 minute left. I want to honor our time, and I know everybody's busy. Any final thoughts from anyone?
I'm excited to start looking into some solutions here. Like Matt said, we've spent a couple weeks or a month now admiring the problem, and I'm ready for a checklist of things to do.
Yeah. I was going to say on the call too, like the Health Rosetta virtual conferences this week, if that's of interest to anybody. So they'll talk about all this stuff live too. So That's
Oh, that could
you
be
can just-
so interesting.
Mhm.
I think there's stuff for physicians and employers and brokers and everybody. So if people want to just Google that.
Yeah. Thank you for that. Anything else? Anybody? Matt, Sherry, Dr. Moore?
Just a quick funny comment. So after we were talking about audits, I dug up my contract. So we've got 1,400 people covered, tens of thousands of claims run through a year. We could audit not to exceed 400 claims, which is probably about 1/100th of a percent
Wow.
or something like
Oh,
that.
wow.
Maybe it's the industry standard. I mean,
Yeah.
yeah.
That's just unbelievable. Wow.
And we could only do it every year and a half.
So 400 claims every 18 months.
Mhm.
Wow. Yeah.
Interesting.
What's the denominator? Is that one lab charge or is that one bill? You know, that like $400,000
Yeah.
bill is one audit. Like, is that one of those universal bills or is that every item on that universal bill?
I would probably assume it would be every individual item because that would work out in their favor, quite frankly, but
Mm-hmm.
it doesn't really define. I'd probably have to go back to the definitions and see how it defines claim.
Is
That's a
that
great
you
question.
having to request the audit, Sherry, or do they just automatically do 400 every 18 months?
Oh, no, we'd have to request it, have a third party conduct it, and we'd pay for it.
Wow.
Oh, of
Oh,
course.
Mhm.
That kills I thought they were trying to defend themselves against excess paperwork, but if a third party is doing it, that defense even falls away. That's interesting.
No kidding.
Don't make it easy.
Okay. We are scheduled just for an hour, aren't we?
Yeah.
Mhm.
Okay. I was thinking, am I cutting us off short? Okay. Well, okay, I'm gonna let everybody go. I appreciate you coming and I hope you'll come to the next one, which would be the 9th, March the 9th, if my memory serves me. And we'll be looking at part 3. I can't tell you what chapters they are, but yeah, getting to some solutions will be interesting. Part 3 are chapters 9 through 13. So thank you all for being here. Appreciate your comments. And if you have any other questions or feedback for us, please feel free to contact myself, Dr. Moore, or Matt. So with that, have a terrific rest of your Tuesday.
Yeah, you too.
Thanks.
Later.
Bye.
Take care. Bye.